And now I invite our Honorable Dean, Dr. Girish Mathur, sir, for his kind words and introduction. Sir.
Thank you, Ashutosh. Good evening and a warm welcome to all esteemed faculty and participants. A special welcome to our patron, Dr. K.K. Parikh, sir, who is always there to support our academic initiatives. It's a pleasure to introduce ICP Roundtable, our panel discussion series that brings meaningful dialogue on evolving clinical paradigms. Earlier, on ICP platform, we started ICP Advanced Clinical Certification courses and ICP Clinical Case Dialogue, a case-based discussion series. Now we bring you this panel discussion-based program. Your response to our earlier program were very encouraging, and I hope you would appreciate and like this initiative of ours also. Today's topic, Beyond HbA1c, Redefining Glycemic Targets in 2026, reflects a timely and important shift in diabetes care. While HbA1c has long been the cornerstone of glycemic assessment, contemporary practice increasingly recognizes the need to look beyond it towards metrics such as time in range, glycemic variability, and individualized targets that better capture patient outcomes and quality of life. We are privileged to have an eminent panel with us today. The session will be moderated by Convenor Dr. L. Sreenivasa Murthy, whose vast clinical experience will guide this discussion. He is joined by an outstanding panel of experts, Dr. Arvind Gupta, a very senior and renowned endocrinologist from Jaipur, Dr. Jothydev Kesavadev, an internationally renowned endocrinologist, and Dr. Mithun Bhartia from Guwahati, who bring rich insights and diverse perspectives to this evolving subject. I am confident that
I think sir has got disconnected.
I think sir has lost connection.
Yeah.
So I now invite our respected patron, Dr. K.K. Parikh, sir, Editor-in-Chief of API Textbook of Medicine. Sir, we would be honored to receive your blessings and words of wisdom.
Thank you, Dr. Ashutosh. It's a pleasure to be here, and I thank Dr. Girish Mathur, Dean ICP, for giving me this opportunity. I think this is the other way of learning, panel discussion around the ICP roundtable discussions. So this is a very important where the panelists will discuss the case and then the delegates can interact with the faculties. So this is the best way of learning, and you just learn everything, and you can satisfy yourself with the queries with the faculty members. So we have got a convener, Dr. Sreenivasa Murthy, who is an eminent physician of great repute. Panelist, we have Dr. Arvind Gupta, our own expert in medicine, Dr. Jothydev Kesavadev from Trivandrum, and Dr. Mithun Bhartia from Guwahati. So I hope we will have a good discussion and a good learning. That is the motto for all what we are having, doing great effort for dissemination of knowledge, which is aim and object of API. That is being fulfilled by our dynamic dean, Dr. Girish Mathur. I welcome Dr. G. Narsimlu, our President of API, Dr. Jyotirmay Paul, immediate President of API, Dr. Ashok Taneja, President-elect, and Dr. Puneet Saxena, all the panelists, convener, Dr. Sreenivasa Murthy, all delegates who will be making a successful program by their attendance. So best wishes, and I hope we'll be much more updated about Redefining Glycemic Targets in 2026. This is a very important topic, and I hope we'll get a lot of information from our top panelist and convener. Thank you very much for the opportunity.
Thank you, sir, for your blessings. Dean sir is here. So, sir, please conclude your address, sir.
I'm really sorry due to some technological glitch. I was logged out. I welcome all the faculty and the participants, and I'm confident that this roundtable will provide valuable practice-oriented takeaways and stimulate thoughtful discussion. I wish you all an engaging and enlightening session. Thank you so much. Without wasting time, I think we must proceed.
Thank you, sir. Our Honorable President, Dr. Narsimulu, sir, is here. I request our President, sir.
Sir, under Parekh, the Greece, all my other dignitaries, Dr. D.P. Singh, I'm very happy to join wherever I get opportunity to join Rajasthan team. Very dynamic team under leadership of Parekh. The number of CMEs that Greece is organizing, it is suffocating for me. My age is not permitting. I wish I might have been a 35 years PG student of Dr. Girish Mathur. I might have taken more. Girish, really wonderful.
Thank you, sir.
Namaskar
Thank you for
with
joining,
hands
sir.
to you. I wish
Thank
to
you,
meet great success. I'll be
Thank you,
joining
sir.
this. And
Thank you.
within Rajasthan, see, Convenor team also organizing within half an hour. They want me to join there.
Yeah.
Girish, you are also joining there, I think.
Yeah.
Alex, sir, kaise ho? And tomorrow both of you coming. I'm eagerly waiting for you.
Yes, sir.
मिलेंगे
Yes, sir.
सर कल रात को 12 बजे रात
Am
को।
I right? Girish,
Okay. Yes, sir.
you are
Yes.
coming tomorrow.
Yes,
Parekh,
sir.
sir, you are also coming tomorrow.
Yes, sir.
DP also you are coming.
Sir.
I wish
Sir.
we meet great success. Thank you.
Thank you,
Thank you
sir.
so much, sir. I request our senior governing body member, Dr. D.P. Singh, sir, for his short comments, sir.
Thank you very much and good evening and warm welcome to everybody. Our Honorable President, Honorable Dean, our mentor Dr. Parekh sir, and everybody, this Sreenivasa Murthy and Dr. Vittal. But really, future Dean will have very difficult to compete Dr. Mathur sir. So every day we are having this CME, every day we are having the new learnings. Thank you very much and congratulations to you very much. And we shall learn about this, what is beyond this HbA1c and this. Thank you very much.
Thank you,
Thank
sir.
you, sir.
Thank you.
Thank you for your kind words. It is now 8:42 and we already have 45 around delegates logged in. So now we move to the academic core of today's program, and it is my privilege to invite the course convener, Dr. L. Sreenivasa Murthy, sir, whose efforts in conceptualizing and structuring this course are truly commendable. May I request you, sir, to kindly introduce the course and take the session forward. Thank you.
Thank you, Ashutosh, and good evening. Namaskar to everybody. Welcome to the first edition of this ICP Roundtable, which is a brainchild of our Dean Girish Mathur sir, and it is an academic initiative as a part of ICP. And as our President Narsimulu sir was telling, this is one of the other suffocating program from Girish Mathur sir. That means we are literally active on a daily basis from the ICP, I think for the first time, which is a good learning, and he's got various programs, and ICP Roundtable is conceptualized about our daily routine problems, questions which can be asked by our delegates, and you get a practical answers from experts in the field. That is what we've been trying to do, and this being the first edition, we have got eminent speakers from across East, that is Mithun, Bhartia. South, we have Dr. Jothydev, Kesavadev, and from the West, Dr. Arvind Gupta. Myself, Dr. Sreenivasa Murthy, a GB member of API from Bangalore, and we will start off with our program, before which I take blessings of K.K. Parekh sir, who's always been our mentor and guide, and also our President, Dr. Narsimulu sir, and Punit Saxena, our Dynamic Secretary, and of course, Ashutosh being the anchor for all these programs, spending time. Thank you, Ashutosh. Now, let's begin with a program today about beyond A1C in concept of 2026, which we want to redefine the targets in 2026. So let's start with some few questions about the CGMs, like the glycemic metrics. Which one should be considered? Which of these metrics are the strongest evidence of predicting outcomes? That is what is most important in clinical practice. And how should the purpose of glycemic target should shape how we set our targets? So, what are the main shortcomings of relying primarily on the HbA1c, or should we move beyond A1c? That is the main crux of the topic today. Now, before beginning, I would request Dr. Jothydev sir to have a brief intro slides regarding the topic of today. Jothydev sir?
Yeah, I am here only.
Yes, sir.
First of all, thanks to LSM for this invitation. And hello to everyone. Thanks to Ashutosh, and always delighted to be along with Parikh sir, our mentor. And congratulations and thanks again to Girish Mathur sir and the entire team. Hello to Narasimhalu sir and the entire team of API. And also hello to my co-speakers, my friends, Dr. Arvind, Gupta and Mithun Bhartia. So this is an introduction for all of us together. And this is a very, very brief introduction. So I will share my slides. As the title goes, this is beyond A1c. So we have been for a long time discussing about there is something to be done beyond HbA1c, since HbA1c will have a lot of limitations in our practice. And maybe in 10 to as high as 20% of our people with diabetes or without diabetes, the hemoglobin A1c may be wrong. It can be wrong. And here I have three beautiful girls. So this picture is created by AI, so don't worry. So all the girls have smiling faces and they represent the same A1c of below 7%. So it appears that if all the people have diabetes, all the three girls have diabetes and they are all under control. But when you are performing a continuous glucose monitoring, you will be surprised to see that one girl is having only 20% time in range, the other girl is having 100% time in range, and the third girl is having only 40% time in range. So this is why now we are recommending, not only in India, all the scientific bodies are recommending the broader use of continuous glucose monitoring. And this is what we usually discuss about beyond the conventional metrics. And when we are performing CGM, the lower limit of a normal glucose is said to be 70. And the upper limit, as you can see in the green colored bar here, it is 180 milligram. So between 70 and 180 is considered within normal range for all practical purposes. And for people with type 1 or type 2 diabetes with no major comorbidities in general, they can achieve a time in range, of course, 100%, but minimum which is required is more than 70% of the time. And roughly for patients, we can tell them that 70% is almost equivalent to or corresponds to 17 hours in 24 hours. And there are also some limits which are set for level 1 below range, that is below 70. And level 2 hypoglycemia is much more dangerous, and that is a level of glucose below 54. And remember, this is not blood glucose, this is interstitial glucose levels. And then you have a level 1 hyper, which is above 180, and a level 2 hyperglycemia that is above the range, that is above 250. And these are the permissible limits for all of these. And this is a journey in India, which is probably very important where we started. I always used to tell my patients that CGM is not new to India. We started off in 2004 in India with the first ever CGM, which is called CGMS Gold. And then there were iPro 2. But the real breakthrough happened in the year 2015 with the launch of a very simple product. And this is the Libre Pro. And all the older devices, they used to be blinded devices. There were no real-time values available. You have to download and then you have to put in some values and then you will get the numbers only after 14 or 7 days or 3 days. But with the launch of the newer devices, this is 2020 launch of Libre in India, and then before that, Medtronic launched the Guardian. And now we have so many devices for continuous glucose monitoring. You can see the picture at the bottom. So we have almost half a dozen devices now available in India. Libre 2 Plus is the real time, which is considered to be the gold standard. and it keeps on changing every minute. So when you monitor, it keeps on changing every minute. And this again, we will be discussing during the panel, the upper limit and lower limit, the percentage which is normal, below normal, above normal, it keeps on changing with respect to whether the person is having complications, whether it is type 1 diabetes, in pregnancy, and so on. And these are the South Asian recommendations published in a reputed journal, where there are recommendations on the frequency of use of a sensor. So now the sensors are lasting for 15 days. And this is how we can recommend, even in people with a normal glucose level, even when the A1C is normal, the minimum use of a sensor which is recommended is twice in a year. That is once in every 6 months. And then, of course, if the person can afford, and the clinical judgment will be the ulterior objective. So you can, as a physician, you can have multiple parameters to decide on the frequency of use of a sensor, but if the time below range or the hyperglycemia is exceeding the recommendations, use the sensor more frequently. So this is a landscape of the available CGM devices currently in the country. On the left, you have the innovators, that is Minimal, Medtronic, and the Abbott, and on the right, you have multiple other devices, and mostly they are from China. Some of them are the same device available in different names in the country. And they are not as good, but some of them are really reliable. So with advancements in technologies, these devices are becoming cheaper, and most of them are becoming more and more accurate as well. But still, the adoption of continuous glucose monitoring is limited, very much limited in the country. And there are currently multiple challenges which need to discuss and then debate. And this is what we call it an ambulatory glucose profile report, consisting of 3 components. And the upper component or the top panel will be the metrics, and the middle you have the ambulatory glucose profile report, collecting all the 14 days together or 15 days together, which looks like a 24 hours model day. And at the bottom panel, you have the individual days of reporting. So this is about the basics of using a continuous glucose monitoring. Sreenivasa Murthy has given only very limited time because we have precious time for discussions to follow. So here I stop. Thank you very much.
Thank you, sir. I think that sets our ball rolling now. Now let's move on to some practical questions, and I would request our esteemed delegates, if they have any questions, please post it in the chat box. So we are ready to answer, and we have esteemed faculty to take up your questions any time of the discussion. Now, let's begin with Arvind Gupta, sir.
Yeah.
How should we individualize the glycemic targets when it comes to the patient factors? Now, which are the patient factors you should consider most important before you set in? Because you cannot afford to prescribe this to anybody and everybody in our practice and Indian context, though it is ideal situation. Please enlighten us, sir.
Dr. Murthy, and at the outset, I thank Dr. Parikh sir, Dr. Girish Mathur sir, Dr. Narsimlu sir, and all the API governing body members and fellow delegates, my convener, Dr. Murthy, and co-speakers, Dr. Jothydev and Dr. Mithun. You have asked very pertinent question. Now, before I answer your pertinent question, most of the patient ask me, what is the difference between, because they always, whenever they are doing the continuous glucose monitoring, they always do once or twice in a day their blood sugar monitoring by glucometer. So they always ask me, what is, there is a difference between the readings of glucometer as well as the continuous glucose monitoring system. So let us enlighten all my patients and counsel all those patients that this is a different blood sugar. So how the differentiation occurs? There are 3 or 4 types of blood sugar in our body. One is arterial blood sugar, where we usually do in the ICU settings, where we do the arterial blood glucose. Another is the venous blood glucose we do, and that venous blood glucose again, normally depending on the laboratory, that some laboratories are doing the plasma glucose, some people are doing only whole venous blood. So that is also actually difference in the laboratory settings. And then it comes to the glucometer setting. It is the capillary blood which we are actually measuring through the oxidase reductase method. And there is a technology and very state-of-art technology by the glucometers they are doing. They are now within less than 30 seconds, you can have the blood sugar. That is a capillary blood sugar. And by the continuous glucose monitoring system, Dr. Jothydev has already alluded to that it is the interstitial fluid sugar we are measuring. So there is always a difference. Earlier, the technology was that when the Libre 1 was there, Dr. Jothydev, you know it very well, that there is a lag period of the blood sugar between the interstitial fluid which we are measuring through the CGMS and the capillary blood glucose by the glucometer. So that lag period also makes a difference in the readings of blood sugar between the CGMS and the glucometer. So that was the earlier concern with most of my patients. Still today, some of my patients ask me, sir, there is a difference of 30 and sometimes 20 to 30 milligram % between capillary blood glucose by the glucometer and the CGMS. So that is the real concern. I want that because Mithun is there or Dr. Jothydev is there, please enlighten, because newer Libre 2 that also minimizes that lag period or the real world setting. So that is the first point. Patients' concerns should be answered very well when we are doing beyond HbA1c. HbA1c is still a gold standard, but definitely there are fallacies of doing the HbA1cs. So let me, clear to the patients as well as counsel the patient first. That is my first point to be very, very clear.
Great, sir. Thank you. Thank you for answering that question and also touching upon the basics, sir, which is many of our colleagues also get confused with the interstitial and the capillary glucose measurements. I think we should enlighten our patients when we approach them. Mithun,
Yes,
what
sir.
are the targets and the difference in monitoring in a newly diagnosed or a long-standing? Should we consider both of them in the same weighing scale, or should we have any difference between newly detected today, I'll jump and put CGM, or I should put only for 10-year, 15-year-old diabetic?
So I'll, before I answer your question, so first of all, thank you very much. It's my pleasure to be in this forum and along all my co-panelists and senior people who are there. So two things Dr. Jothydev and Dr. Arvind Gupta has put into perspective. I'm just, before I answer your question, two very key important parameters I need to understand. I think one person who has never been given due credibility in the world of diabetes is a person called Samuel Rabar. And I would like, and I want to see how many people in the chat box actually know the name of Samuel Rabar. Okay, so Samuel Rabar, I'll come to that. So now if you look at HbA1c, it has been developed. I personally feel it was never a tool for diagnosing of diabetes. HbA1c was a tool that was developed that showed that if it crosses 6.5, there is increasing risk of retinopathy from the DCCT trial. And so till today also, using HbA1c as a diagnosis for diabetes is very difficult. There is not robust data. And in iron deficiency country, very commonly. In my state in Northeast, I often get an HbA1c of 0.0. Because hemoglobin E disease is very common in my state. And so I often get 0.0. So that kind of becomes, HbA1c becomes redundant in a lot of my patients at least. So two important take-home messages, because fortunately, I was at the right place at the right time. So Samuel Rabar is the person, before anybody types, is the person who actually discovered HbA1c. He's an Iranian guy. So he's the guy who actually discovered HbA1c. He never, not many known, popularly known. And the other person who's very famous in the world is Roger Mackay. He's the guy who developed the AGP. And fortunately, I had the opportunity to train with him in Minnesota. Now, two important aspects. So I'll answer this question because I want that to be very people to know this point. Why do we do 14 days of CGM? Why don't we do 7 days? Why does the machine do 14 days? Why doesn't it do 20 days? Why we do 14 days or now 14 to 15 days? Because that was shown by Roger that if you do 14 days and you change nothing, nothing will change. That is how the diabetes will be. And so that AGP curve is made from 4-day readings and it is best at 14 days. That's how Libre started the curve at 14 days.
It's
so
9
from
o'clock.
that perspective. Now what Professor Murthy has asked me this question. You see, when you are newly engaged in a marriage, there is more spice. When it's after 15 years, generally the spice tends to tend off. So the newly diagnosed diabetes is very motivated. He does not want medications. He wants to fight the world, fight everything. For him to get convinced to any form of monitoring is generally very easy because he wants reversal, he wants to change his life, everything. He is there, he's with you. And the other motivating person is the pregnant lady. As the duration of diabetes goes off, it's like, when we are learning to drive a car and after a few years of driving, we don't even look at the mirror. So those people are more difficult to get into monitoring what we can. Those people, to start off with, because people have, today also I had a patient who came and said, sir, where fasting sugar is always good, sir. It's 120, 130. So people generally monitor blood sugar if they do once a day is only fasting sugar. And I moved them from the habit, stop doing fasting sugar. If you will monitor once a day or once a week, you do postprandial sugar. Because at least it will be a little higher. You will become more conscious and things will change. So frequency of monitoring is based on our customer. KYC, we should know our customer. If he's ready, motivated, CGM is gold standard. You can't defy that. You exactly know it's like a video cam. But it depends upon whether he's willing, not willing. And if you have to negotiate just glucometer sugars, a prandial approach at different types of the day is what I maneuver. But the new diagnosed up to 1 year, I feel it's like engagement to marriage. Everything you listen to everybody. So he is the best candidate to change his life and maybe try reversal or remission or whatever we can think of.
Thank you, Mithun. I think it will be remembered. Your examples will be remembered because most of us are married and enjoying, not suffering. Sorry. So let's move on to the audience question. Now we already got about questions there waiting to get answers. The first question is targets in sick patients with frequently fluctuating blood glucose levels. Jyoti sir, can you answer that? Sick patient targets in CGM.
Definitely. I think Dr. Arvind Gupta has raised another issue, and I think that is a very common challenge. People will go on monitoring in the blood glucose meter and will claim that this is wrong. So this is the biggest challenge faced by any physician when we are recommending a CGM. And this has been happening for almost 20 years now with any CGM. And our Vidil Gupta sir has also raised a question that he's having a glucose level which is going up without any reason. In the morning it happens. So with your permission, if I can show just one slide from here. And this is a person where there is a, thank you, Murthy. So this is somebody who is having a nocturnal hypoglycemia. So at the night time, the glucose is around 50, 60, and so you can see so many red colors over there. But when he is waking up in the morning, around 6 a.m., 7 a.m., the glucose is rising, it's going up. And this appears to be something like a Somogi phenomenon, hypo followed by hyper. And this is very commonly observed when you are doing a continuous glucose monitoring. And imagine a situation where you are only looking at the fasting value in your glucometer, and the person is on a basal insulin, and then you will keep on up-titrating the dose of basal insulin, and you might even lose the patient because of hypo during the night, because the person might be having a hypo unawareness. So that is importance, and these are all related to circadian rhythm, multiple hormonal factors, counter-regulatory hormones, early in the morning, and even in the CGM, it's similar to the 3 pyramids in Egypt. The first one will be the biggest one. So the post-breakfast will be bigger than the post-lunch, and the post-dinner is usually the small one. So the So the question of difference between interstitial and the blood glucose meter, it will be there. And that is called the lag time, and it is there. And with development of algorithms, these algorithms have helped us overcome. There are improvements in both hardware and the software in the last 15 years. And the newer CGM devices, the algorithms and the software and the hardware, it has helped us reduce. This is my mother's CGM. There is an alarm coming up, and this is how we remotely monitor. And she is having, I don't know whether it is a hyper or a hyper, and you can have a remote monitoring. And now the glucose is 69 for my mother, and when it is below 70, I will get an alarm in my phone. So all these things can happen. So when you look at the glucometer value can be 75 or 80 now. So interstitial value is different from a blood glucose meter value. And when you are using a non-adjunctive CGM monitor, that is the terminology for CGM sensors which are certified for use without a glucometer, and Libre is one among the non-adjunctive meters, then you can probably rely on the CGM error. But once in a while, it is worth that you check in the glucometer also. But only when you are using more than 50 CGMs in your practice and empowering your patients and getting some experience, you will get to know how you can decipher which one is wrong, which one is right. But the recommendation is you have to adopt this in your practice. Did I answer your question or did I forget your question?
No, you did, and you answered the second question also of Dr. Mithun Gupta. Bonus, 1 + 1 free. So I think it's interesting to see people are curious about this. And now let's move on to another question. The role should TIR, like glycemic variability, time below, time above range, in clinical decision making, what is the role, and should there be a numeric targets equivalent to for these metrics? You are saying 70%. Now, does this like HbA1c 7% translate to an average of 180? Example. So, will this something like this TIR, can we translate this into numeric targets in routine practice? Mithun, you want to take that question?
Yeah, I'll have a different tangent. So I'm just playing the devil's advocate because Jyoti is there. So I'm going to bring some, a little bit of a different tangent, because otherwise we'll say everything is best in CGM is the world's best. We should all move there. So I'm just going to bring a little twist to this story. I think TIR is what we have been doing before CGM. We were doing glucose monitoring, and we were doing structured blood glucose monitoring, which technically was point in range. Okay. Then HbA1c came. And now CGM, obviously CGM, there's no argument about CGM. So you get real time. Why in 2016, when Libre was launched, and Roger had come and done a 4CD tour with him, why was the uptake not happening at that time? Was because of this one reason that Jyoti has said. Because people found it difficult to understand. These are two. I check my glucometer. Ye different hai, ye different hai, ye bekar hai. Because we are used to this. See, anything which is new, we don't want to think. And the worst thing that happened, but there was a terminology called estimated A1C. So because it sounds the same, we expect it to be the same. HbA1c, estimated A1C, we wanted it to be same. That's when, if you see Jyoti's presentation, now the terminology for that estimated A1C has changed to GMI, which is glucose management indicator. Now we don't have a problem because it sounds different. It does not sound like you are comparing with HbA1c. But that was a different point. The point that you were asking me about the time in range that you are looking at, also you have to keep into account the daily curves. Because time in range will tell you 70 se 80%, but you will have to see the glycemic variability of each day mapped with the daily routine of the person to get a better interpretation of timing. Now, nothing is foolproof in this world. HbA1c has a variation of 0.2 to 0.3%, allowed variation. We change our prescription based on that variation. Blood glucose readings has an allowed variation of 15 milligram per deciliter less than 100 and 15% more than 100 milligram. And the same variation is also allowed in CGM. So 15% variation is allowed, and 15 milligram per mg is allowed in the variation as well. So we cannot have absolute values. Answering your question, we should not look at absolute values. What the CGM will tell me is that Dr. Murthy is presently in Bangalore, in one of the posher areas. It will not tell me exactly which house, which flat. That Google location of that is a little not that accurate. But it's still a great tool to have. But absolute values we will have to move by. Whatever values we are getting, it is a range which is plus minus 10% that you should take. So technically the same applies with the glucometer. So what they say is less than 15 milligram, more than 115%. So if you're getting a blood sugar of 150, we are seeing a 15% variation, which is roughly 22 plus and minus. So absolute values we need to go away. We need to look at trends, and that's what the CGM is very good is telling us a trend.
Exactly.
Can I, Dr. Murthy, you asked one important question that the sick people, we want to answer their question very well. First of all, can we rely CGMS during the sick people, especially in the ICU setting? I think no. Dr. Jothydev is here, but there are several fluids we are giving in the sick people, or some so many medications are giving to the sick people, especially in the ICU setting. So we should not rely on that. But still, if you want to do the CGMS in that intensive care setting, I think the TIR should not be 70%. It should be even less than that. That will be okay, because we don't want hypoglycemia at all to our sick patients. So that is the first and foremost thing we want to let the people learn about when we are doing the CGMS. Another aspect is again, other than the targets, is different in the young population. Definitely, you are very, very clear that young, we want even more than 70%, even 80. Why not 80 or 90% TIR and the young patients as compared to the people who are having 15, 20-year duration of diabetes, where we still think of, and with so many comorbidities, like if patient is having chronic kidney disease, or if patient is having angina, or the myocardial infarction, or something like this. So many comorbidities are there. We should actually reduce the target of TIR from 70% to even 50% or so. The most important thing is we don't want too much of glycemic variability, number one, and too much of hypoglycemia. We don't want the people type 2 diabetes with comorbidities. Of course, in type 1 diabetes, the targets are even little not that stringent sort of thing, but especially in pregnancy, the only condition where we want a very stringent criteria of TIR, even 80-90%, more than that, we want that TIR. So I think the targets are different in the different population, depending on the duration of diabetes, depending on the comorbidities, and depending on the other factors.
Thank you, sir. I think it was clear. Jyoti sir, the same question in a different way, I'll put it to you, that what are the factors in an ICU setting, if at all you want to put CGM, what is that factors you need to look into?
Dr. Jothydev?
I think this is a very important question and very frequently asked question. You remember, LSM, during the COVID times, thousands of CGMs were given free of cost by Abbott and Minimed for using ICU. And this was actually meant for remote monitoring. So since doctors and nurses couldn't be there within the ICU, they were slightly far away and they were monitoring from a distance. And then if they need insulin, they used to go inside and infuse insulin. So it works in the ICU, but as you said, and Dr. Arvind ji was also mentioning about the factors. In the innovators, if you look at the literature, there is a detailed description of interfering substances. And the interfering substances will alter the glucose levels. And this includes high levels of vitamin C. In the early FSL1, it was more than 500, but now it is more than 1,000 vitamin C per day, and high amounts of paracetamol. So this is something which can happen even for some glucose meter. So when somebody is having a flu, somebody is having an infection, we have to be more careful. And the glucose levels can be wrong in a CDM. And as we discussed about the medications, for example, hydroxyurea can alter the level. So some anti-malignancy medications, somebody who is having hypothermia, septicemia, you have to be careful. But in more than 95% of people admitted in the hospital or in the ICU, CDM will be working well. You can, in between, you can have some measurements in the laboratory also to find out whether it is right or wrong. But for somebody who is on insulin infusion, or if somebody is having a diabetic ketoacidosis, or if you are going by the glucose as the fifth vital parameter, because so many studies have shown that even subtle increases in the fasting, or when there is a glucose variability, or when the admitting glucose is high, it increases the overall mortality and also CV mortality, and increases the number of days in the hospital, and it increases the number of days in the ICU. But the take-home point is you have to avoid hypoglycemia. So that is very important. And if you have the tools to prevent hypoglycemia, a real-time glucose monitoring is different from the conventional glucose monitoring. So now we have the tools for real-time glucose monitoring, and if you have the option to connect to an automated insulin delivery, and if there is automated insulin delivery, then the hypo is also getting eliminated almost 99% of the time. So these are times when you are safe in achieving a goal of more than 80 or 90%. Otherwise, the common recommendation is, if there is a fear of hypo happening in a person who are having multiple comorbidities or infections or liable to have a hypo-induced complication, aim for only more than 50% time in range. But in chronic care, this 50% can be revised in every 1 month or every 3 months. And if you can safely reach more than 50%, then aim for 60%, 65%, 75%, 80%, and so on. But the time below range in such people with high mortality, high chances of a hypo-induced complication, the level 1 hypoglycemia, that is below 70, should be kept less than 1% of the time. That means almost 0%. 1% in time in range metrics corresponds to 15 minutes in a day. I think that makes clear. I think when we are discussing about the CGM, the major challenge in clinical practice is more than 70% of people coming to your hospitals will not have a NFC-enabled phone. So that is one of the reasons why the Chinese CGMs are also becoming slightly popular now, because they can be used in any smartphone. So that can be used along with the Bluetooth, and any smartphone will be having a Bluetooth. But of course, there will be differences in the accuracy when compared to the innovators. I think
Dr.
Dr.
Jyoti, I want one important, I want to interfere here. One of the important factor is the temperature variation. Like in today's time, we have 40 plus temperature here in Jaipur, and the people wearing the sensor, can we still rely on that? That because of the very high temperature and very low temperatures. So that is also makes a lot of difference. Second, in ICU we use most of the vasopressors, where the vasoconstriction is very, very severe.
Yeah.
So in that situation, also the sensor doesn't have the reliable reading. So in that case, I think we should rely on the glucometers more.
Yeah, Arvind, I agree with that suggestion. More than when a person is wearing a device. So when a person is wearing a device, of course, the temperature will have an influence, especially when somebody is on a insulin pump and there is insulin within the pump. That insulin will lose the potency if the environmental temperature is very high. But with sensors, the major limitation is the sensors have been stored and transported at a temperature preferably below 27. And it is preferred that these sensors are kept within the refrigerator, similar to insulin. So storage, I think, will alter. And this also differs from sensor to sensor. All the sensors need not be kept in the refrigerator. But some sensors need to be stored within the refrigerator and preferably at the door of the fridge. And that alters the accuracy of the reading. I think that is a major problem, and that can happen in the airport when it is, because many of them come from outside India, most of them. So that is one of the reasons why the doctors feel very frustrated using some sensors. They keep on complaining that I'm getting only hypoglycemia, or after 3 or 4 days, the sensor is not working. And most of the time, it is because the sensor is not stored at the preferred optimal temperature.
Mithun, you want to add?
Yeah.
Yeah, so I wanted to add one important parameter that we can use CGMs. Patient post just when they are getting discharged and they are under insurance, put a CGM. Because its insurance will cover that if your hospital has that system in, and he will get a CGM. He will understand, because when he's sick, he's going to go back in his real life. A lot of variation will happen. That's a very nice use of a CGM when the person is about to get discharged. ICU, we can have an argument. I'm not pro ICU. And in COVID, there was a rule because there were some reasons and compulsions. And yes, stable ICU patient. Now, stable, you will never have a stable ICU patient. So if it's a stable blood parameter, blood pressure, everything is fine, then he should not be in the ICU anyways. But ward patients who are stable, yes, you can use who they're. Basically, what you're looking at, and as Gupta sir has said, uska body fluid maintained. So if the body fluid is maintained and there is no, third pocket, first pocket, second pocket, whatever we can say, dryness or overloaded, then even in inpatients, it may be useful, but the best I use it is just before discharge, 1 or 2 days before discharge I do. Education, he goes in, he also, things change, hospital food, nobody lies, house food, it changes, everything changes, so it becomes better. So that is one practical use that I may suggest. There were 3 small questions from Neha, if I could just answer that. Neha, you see, there is always a lag, which has been said, there is a sensor lag, and there is a physiological lag. Sensor lag, where very physiological lag is there. In Abbott, it was 17 plus 5 minutes. CGM in non-diabetic, the question is what is diabetic and non-diabetic in CGM? There is a very nice paper by Viral Shah, and looking at the blood glucose between 70 to 140, which they said is in a normal population. But such data for Indian population does not exist so far. This data is there, but not for an Indian population for us. So whether that, how much of validity that has happens, it may cause more anxiety among patients that is there. Cost effectiveness in a low resource setting. I learned this trick when I started practicing in Guwahati. I went to a rural town and I saw a person wearing a yellow dhoti with holes in it. I did not know what to prescribe. And I was just thinking, 5 minutes I was asking him, 100 rupees ka tablet, 10 rupees ka tablet, all that discussion I was trying to bring. His relative said, sir, please come out, look at entire your eye, the whole land belongs to him. So let that, and I traveled to Shillong where the patient says, sir, you tell me what is best. Whether I afford, how I afford, what I afford is my responsibility. Let us not be judgmental. Let us give them the options. They will choose. Like now we have semaglutide, all kinds of pockets are there. You tell them what they can do long term. So that is, I take that with a pinch of salt. And I think that answers Neha's all the questions that has been.
Yeah. So Mithun, I'm not paying you remuneration today because you're stealing my job of moderation. You're taking the questions.
Oh, sorry. I wanted to answer that question.
We are happy that our panelists are enthusiastic to answer questions. So please keep posting.
We are all proactive.
Exactly, sir. Exactly. There is no lag period at all in answering. So let's move on to the next question, Arvind sir, to you.
Yeah.
What is the relevance of A1C measurement if the patient is very compliant on the CGM system? Dr. Abhay Singh has asked about this question.
As I understand the question,
yes, sir,
that which is better, A1C or it is the CGMS?
If a patient is on a very compliant and comfortable with CGM, affordable of course.
Yeah.
Is there any relevance of A1C at all?
Yeah, I will rely on both. This is my first answer is very clear. Even the compliant patient, very who's having almost, I have got 1 or 2 patients who are wearing CGMS for almost 2 years. They are regularly wearing the CGMS, but still I'm doing the HbA1c level. My most important thing, matrix, is the micro and macrovascular complications in diabetes. That is again a very, very important thing. So, because we have so many studies, even UKPDS study, the all other studies, DCCT studies, Kumamoto studies, they rely on the HbA1c for micro and macrovascular complications. We don't have that much of data with the CGMS, though we have still the data of CGMS, which if you have a TIR more than 70%, you have less micro and macrovascular complications as compared to the people who have only 40 to 50% TIR. So that is again the things, but that data is not that robust data, which most of the association does not, endorse that CGMS for the micro and macrovascular complication, whereas HbA1c is definitely having correlation with the micro and macrovascular complication, and all the big studies clearly said. So my answer is very clear, short, and is very crisp answer is that we, even with a compliant patient who is wearing CGMS for a longer period of time, still HbA1c is required. This is my particular thing.
Thank you, sir.
I don't know,
Jyoti sir, about EMR, can we incorporate any of these models data automatically into EMR? Like you just now showed your mother's live 69 as hypo beeping. But can we incorporate this to automatically to our EMRs? Is it compatible, any of the models?
The innovators such as Abbott are actually doing this, and they have already done it in China. And they have also a model for hospital use, a CGM for hospital use, and they have connected their software to some of the softwares in the hospitals in China and some hospitals in Japan. But for us to do it, actually, there is no permission from them. So it is not possible. So how do we do is, there is a LibreView available. So the entire data is stored in the cloud. So in the cloud, you can download, and that we download and then connect to the EMR. So when the patient is coming for the follow-up, the previous reports will be there. And if it is not available as an ATP report, then we will pull down the ATP report every time online from the LibreView. So when the patient is there for the consultation, the LibreView will also be open. I think with respect to the question A1C, Dr. Arvind has answered the question why we should be doing A1C in the era of CGM, because you know that CGM is a technology, and A1C is also a long-standing technology, but the A1C can be wrong. There are many people where the A1C can be 4 or 5 or 6 very low values, and the A1C could be wrong because of hemoglobinopathies, or the A1C can be wrong because of anemia, pregnancy. A person who is having chronic kidney disease on erythropoietin, the A1C is wrong. So it depends on multiple factors, especially the lifespan of the RBC. So in many cases, this is better, but that depends upon the algorithm. It gives you the glucose management indicator from the values along with the algorithm. And the GMI is pretty accurate with some CGM such as Libre, but the GMI can be higher in some other Chinese CGM. So you cannot rely on the A1C from the CGM. And Vidul Gupta sir has also mentioned about his values, and I asked him a question whether he is calibrating or not. For the Chinese CGMs, there is an option for you to calibrate, sir. So this is an answer to Vidul Gupta sir. I am not.
No, he is calibrated 7 times in 4 days. That's what.
That is also very important. Don't calibrate more than 2 times. You have to calibrate only once, and the calibration has to be done preferably on the 3rd day. So they have done some studies, and preferably pre-breakfast when the glucose is very stable, and then usually it will work. But believe me, these CGMs are very good, but they cannot be as good as innovators, because this is true with any not only technology, with any drug also. I think we still prescribe augmented. When I am having an infection, I take only augmented. So there can be difference between the innovator and the generics, and with technology it could be probably more right in choosing the right one. But for many people who doesn't have an NFC enabled phone, this is working with any phone, and it is relatively cheaper also. And the one that you are using, Gupta sir, it is available under different names in India, but they are all the same CGM. And it comes with the app. And in the app, there is an option for you to calibrate. And though it is the same CGM, some other apps which are used by the others for the same CGM, they are slightly better than this one. I can only reveal this much.
we understand, sir. So thanks a lot. I think we are approaching our closing time. So I would request each of the panelists to give a one-liner take-home messages to our esteemed audience.
I think before we go for the one-liner, again a question is there. I think we should answer that. Dr. Geeta Arora, she says she wants to ask how to manage patient with good HbA1c but poor TIR or vice versa. I think this is a very important question she has asked. That
Please,
patient is having a good HbA1c but TIR is very poor. So I think in that case it is the hypoglycemia per se. That is very important. We have to look for that. Now, for example, and one question was asked for the non-diabetic. What we have recently done CGMS in a reactive hypoglycemia patients. Patient was getting regular hypoglycemia, is a non-diabetic person. So in that case, we did C-peptide, we did insulin, we did all sorts of insulin growth factor, everything that was always coming normal. We did the CGMS in that patient, and what we found, it was the postprandial hypoglycemia, always there. So, Dr. Jyoti, that case was very, very important. That thing, we did all sorts of hormones that were normal, even cortisol, HbA1c, insulin growth factor, C-peptide. We did everything. Everything was normal, but still the patient was getting the hypoglycemia regularly. In that case, we did the CGMS when we found very important thing is that the carbohydrate per se or the high carbohydrate or postprandial hypoglycemia always was there with that patient, and within 14 days we could find that the way to curb that hypoglycemia, because we specifically changed the diet pattern of that patient, and within 14 days we could find some treatment point of view. So that is the thing. Now my one-liner is that we should do the capillary glucometer. SMBG is still there. There is always a debate in our conferences. Self-monitoring of blood glucose is still relevant, but CGMS, because it is there, we should use more of the technology of the CGMS, and of course HbA1c we should still rely on HbA1c. Of course, Dr. Jyoti has already pointed out fallacy of having HbA1c in hemolytic anemia, abnormal hemoglobins, or severe anemic patients. So false high and false low HbA1c should be there. But in spite of that, HbA1c is still relevant. So my one-liner, we should rely on all three parameters. They are very, very good depending on the special situations.
Mithun, your one-liner?
So my one-liner is always an analogy. See, nobody is perfect. Nobody is perfect. So in a marriage, you do not get a perfect husband or wife. You get a good enough husband and a good enough wife. So similarly, we are good enough doctors who brings in account whatever the recent technology and try to do for the good enough patient that comes in.
Thanks a lot. Thanks a lot. Very wonderful and very practical.
He always relates with the marriage.
Exactly. Always relating to marriage. He is very confident that his wife is not on the program. So Jyoti sir, your one-liner.
Yeah, dear LSM, I always believe that after insulin in diabetes, the next biggest discovery is continuous glucose monitoring, which has even led on to the innovation of an automated insulin delivery. And this is something indispensable in the management of diabetes or in pre-diabetes, and has to be advised in every person with pre-diabetes or diabetes.
Thanks a lot, sir. Thanks a lot. And I think by the participation of the delegates and for a change, our esteemed faculty were also very enthusiastic to take up questions voluntarily, proactively, which we appreciate. It's like a very understandable wife in Mithun's language, which is rare to get of late. But we got such a good.
So now we have to listen whether your wife is in the house with you or not when you say that comment.
So I think the first program is successful. That is what we feel, and hope all of you have enjoyed. And next month, the last Thursday, would be again the ICP roundtable will come up with a interesting topic, and just to reveal, it will be about SGLT2 and GLP-1s synergy. That is what we're going to talk about. The next topic with the interesting panel, which will keep you updated. And we sincerely thank the ICP team headed by our Dean Girish Mathur sir for this innovation roundtable, which is one of a kind, which is not the same routine slides and one-way lectures and all of us switch off and do our practice, etc. Instead, we saw people participating very actively, very enthusiastically, and that is what is the key motto of this roundtable ICP of API wing. And next month, we definitely come back and promise with the interesting panelists and open to all of you for active participation. Again, sincerely thank. And Ashutosh, you are around, and
Mayor sir, thank you so much, LSM sir, and all our panelists.
Yes,
For steering discussion so effectively and ensuring a meaningful exchange of ideas. And I think we have explored how diabetes care is moving towards a more comprehensive and patient-centered approach, integrating newer metrics like we have discussed, time in range, and addressing real-world clinical challenges. So our sincere gratitude to our course convener, Dr. LSM sir, and our distinguished panelists, Arvind Gupta sir, Jothydev sir, Mithun sir, and all our esteemed senior leadership. And I thank all participants also for their enthusiastic presence and engagement. We look forward to your continued participation in upcoming ICP academic activities also. Thank you and have a wonderful evening, sir.
Thank you.
Thank you.
Bye-bye.
thanks a lot. Thanks, everyone.
Thank you.
Thanks for your presence.
Bye bye.